Good afternoon and welcome to today's Grand Rounds presentation entitled Physician Communication Coaching, How Coaches Can Elevate Skills and Support Resident Education, Professionalism, and Wellness. A few housekeeping items before we get started with today's session. Some of these, of course, are quite familiar. Mics and cameras are off except for those who are speaking and interpreting. And then we invite you all as participants to please use the Q&A box on the toolbar to share questions or comments along the way. I'll be moderating that Q&A box such that at the end of our presentation today, we'll have some time for discussing the questions or thoughts that come up as you're listening today. There are a few ways that we welcome and invite your feedback and also receive continuing education credit using the evaluation form. The first way is that a survey link will be posted in the chat near the end of the presentation, so keep an eye out for that. But also an email will be sent out containing the link the day following the webinar, and the webpage with the survey link will also pop up as you're leaving the webinar. And just by way of introductions today, we have a powerhouse team getting ready to share some really innovative programming and educational innovation with us. It's my pleasure to introduce the team today, including Dr. Andrea Garraway, who's an assistant professor in psychiatry and medicine, the assistant program director for communication, coaching, and wellness in the internal medicine residency, and the director of behavioral health integration at Strong Internal Medicine. She teaches patient and family-centered communication skills, psychosocial medicine, and also promotes efforts supporting physician wellness. Her professional interests also include integrating mental health into primary care settings and teaching trauma-informed approaches to healthcare professionals. Dr. Keisha Bell is an assistant professor in the departments of psychiatry and also OBGYN. She completed her PhD in clinical psychology from the University of North Texas with a focus in health psychology, and her internship at the Cleveland VA, as well as a 2-year postdoc here with us at the University of Rochester in primary care, family psychology, and women's health. As a communication coach and educator in the Department of OBGYN, her work focuses on teaching patient and family-centered communication skills. Dr. Bell serves as a co-officer of diversity and inclusion in the Department of OBGYN. In her role as an embedded psychologist in one of those outpatient OBGYN practices, she also provides consultation, education, and brief therapeutic support to adult women across major life stages. Dr. Lauren DeCaprio-Ryan is a clinical geropsychologist and associate professor of psychiatry, medicine, and surgery housed within the Institute for the Family. She's the Associate Director of the UR Medicine Coaching Program, Communication Program, and Coaching Academy. She also serves as Associate Chief of Psychology and Associate Director of the Integrated Care Family Psychology Fellowship. And as well in general surgery, she's an Associate Program Director in their residency program with a focus on resident wellness, and she oversees their communication and leadership development curriculum. Finally, Dr. Susan McDaniel is the Dr. Laurie Sands Distinguished Professor of Families and Health at the University of Rochester Medical Center. In our own Department of Psychiatry, she's the Chief of Psychology and the Director of the Institute for the Family. In addition, she serves as the Vice Chair of the Department of Family Medicine and also the Director of the UR Medicine Physician Communication Coaching Program, which you'll hear obviously quite a bit about today. Her career is dedicated to integrating psychological and relational science and practice into healthcare and has won many awards, having also been the author of over 100 journal articles and 17 books translated into 10 languages. She's been the editor of Family Systems in Health and the associate editor of the American Psychologist. She's a frequent speaker at national and international medical and mental health meetings. Dr. McDaniel has also served in many leadership positions in both primary care as well as mental health associations, among them having served as the president of the American Psychological Association in 2016, and she's currently on the APA Council representing the Society of Health Psychology. Without further ado, and based on the size of our team and a lengthy but important set of introductions, I would love to turn this over to our team of presenters this afternoon, I think beginning with Dr. McDaniel. Thank you. If our current speaker is muted still, we'll just invite you to unmute and to unmute your video as well.
I think I'm squared away. I'm just sharing the screen. Okay, so I think we're all good. I'm so happy to be here to speak with you all today with my really talented group of colleagues and to talk about the application of the physician communication coaching program to residency programs. So we don't have any conflicts of any kind with anybody. We do want to acknowledge the communication coaching program was the project, the systems-wide project that I did when I represented UR Medicine at the Executive Leadership Program for Women in Academic Medicine. So I appreciate all their support and consultation in the development of the program. Just one second, sorry. Okay. Lauren did a project evaluating faculty coaching that was supported by the Macy Foundation. And we also want to recognize Chris Henry, the Institute AA, who gathers evaluations about the physician's experience in the program and also supports our presentations about the program. So after the presentation, you all are going to be able to identify how communication coaching contributes to the evaluation of 2 residency milestones. You'll be able to describe 2 key skills involved in being an embedded communication coach and describe the relationship between communication, professionalism, and wellness. So really the focus of the overall University of Rochester Physician Communication Coaching Program is to help create a culture of feedback and wellness that's based on relational and systemic principles and that enhance self-awareness and lifelong learning about communication. The development of the program came in 2011, 2012 at the request of our dean in response to patient complaints and because patient satisfaction was soon to be a driver in reimbursement. So Dean Taubman asked me to create something as part of this ELAM project that would help with patient satisfaction. And that's the genesis of the program. I like this quote by George Bernard Shaw: "The single biggest problem in communication is the illusion that it's taken place." But I also really like a quote by one of our senior coaches and presenters today, Keisha Bell. Keisha said, "The goal of the program is to see patients accurately and intentionally and to see ourselves accurately and intentionally." So I think that really says it all. So to start this program, I did a pilot study during that 2011-2012 year to see what our physicians across the medical center might need. The participants were 6 surgeons and 6 cognitive physicians, 6 with high patient satisfaction scores and 6 with low scores. And it turned out to be 8 men and 4 women. I also looked at feasibility and physician satisfaction with the program in this pilot. So just briefly, the program's based on 30 communication behaviors from the Cambridge-Calgary Patient-Centered Observational Checklist, plus some items from my research about communicating with family members and recognizing emotion in patients. We watch the physician for at least 4 hours and code quantitative and qualitative data about the physician-patient family interaction. We compile the data, write and send an extensive detailed report, painting a picture of the physician as communicator. And then we meet with the physician to debrief the experience and discuss what we see as their strengths and recommendations we might have. The results of the pilot were that of the 40 communication skills, I really honed in on 3 that I knew were associated in other studies with high patient satisfaction and quality measures. And it showed that our physicians' performance on these 3 skills predicted whether they were in the high or low patient satisfaction group to the P.001 level. So I felt like, okay, this is a good approach and it has an evidence base, both in patient satisfaction and in quality measures. We also looked at the feedback from the participants. And this was their initial feedback of the first 12 that I did. 60% found the process very helpful and 40% helpful. So I was happy with that since it was the first 12 physicians I ever coached. Their comments included, she showed me all the things I was doing correctly and pinpointed some areas that could be tweaked in the future. I think every provider in our department should meet with her. I believe this type of experience is valuable since habits, good or bad, creep into communication. Very professional and insightful. I'd like to do this again. She made me realize that I did a lot of teaching, but didn't always elicit patients' concerns. And then my favorite comment from the study, very helpful indeed, even though it was truthful. So once it was clear that the program was valuable, the dean asked me to coach all the senior associate dean for clinical affairs, all the clinical chairs, and many of the division's chiefs, so that these leaders would know firsthand about the program and its possibilities for their faculty. I realized then I needed help to expand the program and began to think about colleagues who might be interested and skilled at doing this work. The dream team for the first 7 years or so were all talented colleagues, as you can see, with deep experience in medical education and psychotherapy. Colleen Fogarty, now chair of family medicine, Lauren Zapora, Dave Seaburn, who's now retired, and Bill Watson. And as you know, of this early group, Lauren, Zapora, and Bill still work as coaches. So in 2011 and 2012, that was the time of developing the pilot. In 2013, after pulling together this team, Lauren expanded our coaching into the surgery residency program. So that was our first attempt at applying it to residents. In 2017, Andrea and Keisha became embedded coaches in internal medicine and OBGYN, respectively. And in 2018, Lauren and I developed a 2-year training program that you're going to hear about. We're training now faculty, including psychologists, family physicians, and a psychiatrist. And we have 5 psychology postdocs in training to be communication coaches. So through this training, we've added 4 more senior coaches to our team that works across the medical center with faculty. And these include Keisha Bell, Andrea Garraway, Jessica Moore, and Lindsay Sish. And now over to Lauren. I'll stop sharing my screen.
Thanks, Susan. It's my pleasure to be here with you all today and begin to tell you a little bit more about the specific application of coaching across our different learner groups. Over the course of our program history, our coaches have now supported 18 departments. We have coaches embedded in 11 clinical departments, some of which actually have multiple faculty and fellows serving in this capacity. This team has coached nearly 340 residents from across the institution, many more than once, supporting their sustained behavior change and growth during the course of their training. Most recently, we're really thrilled to say that Dr. Becca Kopek is taking the lead in launching this initiative within the psychiatry residency program, and are grateful for the support of our educational leaders to help see this come to fruition. In addition to our residents, we have coached over 240 faculty, as well as fellows, advanced practice providers, and some in non-clinical roles. Each department and learner has come to us with unique needs, strengths, and motivations. With everyone, we follow a standard protocol that you'll hear more about and tailor that then to meet their individual learning needs, which allows us for a consistent, high-quality learning approach. In 2015, Dr. David Lenahan, the chair of general surgery, supported the expansion of our coaching program in general surgery, conducting a pilot program looking at the role of peer coaches in addition to our embedded coaching experts. As part of this, he helped us develop a series of videos capturing best practices and worst case scenarios. We'd like to share one of those clips with you now to highlight the number of communication behaviors that can be observed even in a short amount of time. Note that this video is intended to capture an average event, demonstrating how most of us enter dialogues with patients and their families with their own communication strengths and areas to improve upon.
Good morning, Mr. Weber.
Good morning.
Hi, I'm Dr. Linehan. David Linehan, nice to meet you.
Hi, how are you?
Hi.
I'm his wife, Marta.
Hi,
Thank
Martha.
you for
Nice
coming.
to meet you.
His daughter, Erin.
Hi, Erin. Nice to meet you. I'm just going to sit over here.
Okay.
So tell me what you know. What have your doctors told you so far?
It's a little overwhelming. Understand that I have cancer.
Mm-hmm. And did they tell you what kind of cancer?
Pancreatic cancer.
Pancreatic cancer. Okay. And so they sent you to see me because we treat a lot of patients with pancreatic cancer, and you know that's what we're here to talk about, the treatment strategy and the plan related to that. So how did this all start?
Just noticing some weight loss, and I wasn't feeling like eating much, and had some low back pain, and I thought nothing of it, but Marta, who's pretty insistent that I go see the primary care guy, and they ran some tests, and now here I am.
Okay. So, and then they did a scan and showed the tumor in the pancreas, and then they did some biopsies of it, and they confirmed that it was cancer.
They ran some tests, yeah, they all that stuff.
Okay. And how are you feeling right now?
Frightened.
Frightened, okay. Are you having any persistent symptoms? Is the back pain still there?
Yeah.
And you're continuing to lose weight and struggle with your appetite?
Yeah.
Okay. And have you been vomiting?
No.
No. Okay. And in terms of your family history, has anybody else in your family had pancreatic cancer?
Not that I know of.
Not that you know. Okay. All right. And so, have you obtained any other information? Has your doctor told you? Have you been on the internet? Have you?
No, I'm scared to look.
Okay.
I just know what happened to Steve Jobs, and it was not a good outcome.
Yeah. Okay. Well, the treatment of pancreas cancer typically involves surgery if the tumor is still contained and hasn't spread. And based on my review of your films, it looks like that's the case for you, which is good, because the majority of pancreatic cancer patients, when the cancer is diagnosed, it's already spread, but we don't see any evidence of spread on your X-ray. So that's a
They can take it out. You can take it out.
That's a better place to start.
That's a relief.
So yeah, so if the tumor is still contained, then we typically would recommend surgery, and in some.
As this clip demonstrates, in just 3 minutes, a clinician can do a tremendous amount to set the tone of the relationship with a patient and their family. As you already heard, introducing oneself and checking for the patient's concerns are 2 key features of an encounter with improved satisfaction and outcomes. Embedded in this clip, you also likely picked up on other factors. How are family included in the discussion? How is emotional expression managed, or as we often see, ignored? How is the diagnosis explained? And how much space is made for a patient and family to engage in shared decision-making and dialogue? The work of coaching is not limited to outpatient interactions. Our team can also be found joining morning rounds, interdisciplinary team meetings, and moving between inpatient and outpatient settings based on the clinician's growth edges. We've adapted our coding and also have protocols for coaching in the operating rooms and procedural settings and in acute care settings included in the ED and CPEP. Graduate medical education is generally largely focused on medical knowledge, differential diagnosis, and competence in intervention in surgical and non-operative specialties alike. Though there are formal efforts to develop communication skills in medical school, residency programs often struggle to provide education in this domain. Since the Institute of Medicine's emphasis on communication skills and the ACGME's inclusion of competency-based milestones in this domain, programs have been exploring methods that support their learners and their patients. Graduate medical education was also managed what Hafferty defined in 1998 as the hidden curriculum, which influences physician identity development as students absorb the commonly held understandings driven by institutional, systemic, and cultural guidelines. Trainees entering residency are often navigating systems that have established hierarchies that influence interpersonal and team dynamics. They're navigating new time management skills, new levels of clinical volume, patient complexity and acuity, their own fatigue, physically and emotionally, and are making the transition from student to professional, requiring adaptation and skill development related to professionalism, including attention to their own well-being and processes of self-reflection. It's been our experience that as residents juggle these many challenges and adjustments, that communication skills can often help us recognize someone struggling, as problematic communication can often be a symptom of burnout, depression, or anxiety. We'd like to capture the intersection of communication, professionalism, and wellness by sharing a brief vignette that we invite you to consider through the remainder of today's presentation. The story is a composite of actual experiences in resident communication coaching using fictitious names. Inpatient nurses paged a third-year resident, Dr. Smith, several times regarding Mr. Jackson's care. Busy with other patients, he forgot to respond. At 10 p.m., he remembered the Jackson family was waiting. Despite being exhausted, he went on to the unit. Mr. Jackson's nurse warmly stated, "Good, you finally made it. I hope they stuck around." Frustrated, Dr. Smith snapped, "What do you mean you hope they're here? Didn't you tell them I was busy?" He didn't pause long enough to hear the reply, but instead entered Mr. Jackson's room, found him asleep with his wife sitting nearby. "Mr. Jackson, wake up. You wanted to speak to me? Did you want me to talk to, is it your wife?" Mr. Jackson barely nodded before dozing off again. Sighing, Dr. Smith turned to Mrs. Jackson. "Is there something I can help with?" Mrs. Jackson was tired herself and worried, and also a bit dismayed by Dr. Smith's approach. She paused and then replied, "You are?" Dr. Smith shared his role, but never actually introduced himself. "I'm the resident overseeing your husband's care." Mrs. Jackson explained, "Your team said conversations about my husband's treatment need to go through you. My daughter has a lot of questions." "And they are?" Mrs. Jackson recognized that the dialogue was not progressing in a helpful way and encouraged him to be in touch with their daughter, who was also their healthcare proxy. Dr. Smith was dismissive and ultimately interrupted her. As he left, he told Mrs. Jackson to direct any remaining questions to the nurse. Mrs. Jackson called the nurse and shared what happened. The nurse contacted the attending, who appropriately followed up with the Jacksons and also provided written feedback to Dr. Smith. Her feedback included a summary of the day's events and the poor communication observed by multiple parties. She copied in the residency program director. This was the second concern identified in a short window regarding Dr. Smith. The program director met with Dr. Smith, who took no ownership for the prior events, expressing only that there were limitations in an 80-hour work week rule and that he had set boundaries with the patient appropriately in his mind. The program director advised that the resident should work with the coach and sent a communication directly to the coach requesting this support. And with that, I'll hand you over to Dr. Keisha Bell.
So Dr. Smith's interactions with the patient, the family team, the program leadership all suggest that there are some growth opportunities in several milestones related to residency programs, including interpersonal and communication skills and professionalism. Yet data suggests that clinicians tend to overestimate their communication skills and may be unaware of communication blind spots that could impact the quality of their clinical encounters. So communication coaching provides a direct assessment and functional evaluation of these milestones and skills. Related to interpersonal skills, we'd be remiss to omit the role of culturally insensitive communication on care quality. The Institute of Medicine's landmark report, Unequal Treatment, highlighted that factors within the clinical relationship, such as power imbalance, clinician unintended bias, and clinician communication skills may contribute to health disparities among racial and ethnic groups. For example, studies showed that BIPOC patients experience poorer interpersonal communication than white patients during their office visits. And physicians tend to provide less information to BIPOC patients, engage in more narrowly biomedical conversations, so data gathering, patient education, and spend less time building rapport. Physicians are also more verbally dominant and less patient-centered with Black patients in particular, and have shorter visits with these patients. BIPOC patients report less involvement, a sense of less involvement in their care, less partnership, and a decreased sense of trust with their physicians, and lower levels of satisfaction with their care. There's strong evidence in the social psychology literature that implicit racial bias can influence nonverbal behavior, such as body posture, eye contact, nodding, and paraverbal behaviors, such as the amount, speed, and pitch of the speech during interactions with BIPOC patients. And so some scholars contend that improving provider communication behaviors might be a more practical and attainable approach to improving care outcomes for Black patients or BIPOC patients than strategies focused solely on increasing awareness of implicit bias, but that don't provide any concrete next steps. Next slide, please. So what is the communication coaching process? Dr. McDaniel mentioned a little bit of the process a moment ago, but communication coaching involves direct observation of clinical and or interpersonal encounters with patients, families, and work colleagues, and it occurs in 5 steps typically. First, the coach and resident arrange an observation time. Typically, they discuss the coaching process and identify goals via email. After that, the coach will observe a resident during a 4-hour block of clinical time and record their behaviors using that observational checklist that Dr. McDaniel mentioned a moment ago, and any physician, patient, family interactions during that block of time as well. Just want to take a moment to reiterate that the communication coaching is strengths-based. So it's not an aha, I caught you doing something bad, kind of a educational opportunity. And I know that a lot of physicians or clinicians are nervous about that, but they're often surprised by some of the strengths that are noted during the feedback session. So just want to reiterate that it is a strengths-based approach. The coach then compiles the quantitative and qualitative data into a comprehensive written report, sends that to the clinician ahead of time to give them time to read that and synthesize that. And then they meet for an hour-long feedback session. The feedback that's provided is it encompasses a lot of different topics. So the actual observations from the coaching session, their specialty culture, how things kind of work in their particular department, career development, personal goals, et cetera. And it's delivered in a constructive and supportive manner. Again, not an aha, I caught you. The resident and coach then identify an area of focus that the resident will work on for the next several months or until the next coaching observation is, if one is provided. Afterward, the coach then provides a summary of information and milestone competencies only to the residency program director. So the report in and of itself is for the learner, and the residency director will receive just the milestones and competencies. Next slide, please. So coaches use an expanded version of the Calgary-Cambridge observational checklist. And so we provided here an example of a coding category related to information gathering that we would be coding for during our observation. So for example, did the clinician set an agenda up front, or did they just delve into the problem? Did the clinician ask the family member or loved one about their particular view of the problem, or did they ignore their presence in the room? And we know that patients pay close attention to how we treat their loved ones. Another is using open-ended questions appropriately. So strategically asking open-ended questions throughout the interview. Did that occur? Did it not occur? And so we take a tally of the number of times these behaviors occurred in each visit and note any additional qualitative observations. And although these seem pretty simple and straightforward, they don't happen consistently. And they can really impact efficiency, rapport, and trust if not attended to. Next slide, please. Oh, sorry, I think I jumped ahead. I have one other thing to mention. Sorry about that. So let's just return to our vignette of Dr. Smith. So Dr. Coach observed Dr. Smith with patients, family, and his team. She compiled a detailed report, and during feedback, Dr. Coach emphasized his strengths, including interacting well with patients and team members individually. She noted opportunities for growth when multiple people were in the room, specifically acknowledging everyone, gathering their perspectives, and ensuring that plans were realistic and acceptable to patients and their families. She also discussed the experience of BIPOC patients feeling unheard and rushed and dismissed, and highlighted behaviors that may contribute to patients feeling unheard, such as kind of the shared decision-making, Dr. Smith's tone with Mrs. Jackson, his dismissiveness of her concerns and interrupting her while she spoke, and how this could hinder collaboration and trust, especially for individuals from minoritized communities. Dr. Coach gave feedback related to professionalism, such as timing the meeting when the patient is awake and the family alert and available. They discussed strategies for maintaining a professional stance despite frustrations or workload. Dr. Coach shared evaluations of Dr. Smith's competencies in relevant milestone domains. Dr. Coach also discussed how well-being is directly tied to one's ability to bring empathy, compassion, and patient and family-centered care to one's work. Dr. Smith shared significant family stress and noted that he was feeling overwhelmed. Dr. Coach suggested he might benefit from meeting with a therapist, and that many residents have found this helpful. She normalized this experience, noting that others have found it useful to learn some stress management strategies. Dr. Smith was interested and took contact information for a behavioral health service within the institution. Dr. Coach reviewed the report and that she would be sharing this with program leaders. This summary included his communication strengths and opportunities for growth, willingness for future coaching, and with his permission, the impact of personal stressors on his functioning and acceptance of a referral for support. And so for the conclusion of this vignette, you can see how attention to well-being, communication skills, the patient, family's experience are all highlighted during the debriefing session, and that there is a greater level of awareness of previous blind spots that the resident may not have been privy to before having the coaching experience. So with that, now we'll turn it over to Dr. Garraway to discuss the coach's skill set.
Thank you, Dr. Bell. So I'd like to transition here a bit and talk about us as communication coaches and the skill set that we found to be helpful for being effective in this work. So first, skills around behavior change are really essential to this work. For example, we work to collaborate with those that we're coaching on realistic goal setting, discussing strategies to reinforce skills. Self-monitoring techniques are also a big thing that we talk about, ways to sort of improve awareness or time awareness. For example, setting timer or having a pager go off or buzz at a 10 or 15 minute mark in the room if a person is struggling with some efficiency, to just build up those skills around awareness of how much time has passed and work on pacing. Another skill set that we feel is really helpful in this work is for us coaches who work in an academic health center and have experience as medical educators. We're able to understand the culture of different disciplines and specialties, especially those of us that are embedded in the different programs, how to sort of speak the language to teach certain communication skills to fit within a specific context. So for example, what does setting the agenda of a clinical interaction look like in an outpatient setting versus in an inpatient setting? How there are definitely some similarities, but how there might be some differences in what you adapt, how you adapt that skill. Lastly, we've also found that some basic psychotherapy skills are useful during feedback and debriefs to be able to tie the communication behaviors that we're discussing to personal motivators or reasons why someone pursues medicine in the first place. These skills are also really helpful when issues related to wellness come up. So for example, discussing how communication with patients or teams is negatively impacted by burnout, how residents are coping with the various demands of residency, and what support systems they have in place. So we surveyed our psychologist coaches, and I have listed here and then on the next couple slides some quotes from them about their roles as coaches. So in terms of how being a mental health professional helps or hinders their role as a coach, you can see in this first quote here, this person is really highlighting the systemic framework that's important to this work, understanding behavior in context and understanding the learning process. We see some similar themes in the second quote here. This person also is highlighting skills around language, which is a really big piece of how to frame feedback, not only in the written report, but also in the debrief in a way that that is strengths-based, as Dr. Bell pointed out, but also perceived as supportive rather than critical. And then also being able to provide developmentally appropriate feedback that's based on our assessment of their skills and their goals. Next slide, please. Okay, so what is in it for the coach? What do we enjoy about coaching residents? So certainly this is dynamic work. It's challenging, it's fun, it's a unique application of our skills. And these were some responses from the coaches we surveyed, highlighting the work itself as being very rewarding and feeling like it has wide-reaching benefits. One person also highlighted that in many cases, they feel that their role can help change the conversation from someone who's problematic or unprofessional to instead needing some other kind of support. Next slide, please. So what's challenging about coaching residents? One of the things that's challenging is logistics and scheduling. Resident schedules are very complex, and partnering with residency program administrators or chief residents to understand their schedules is very useful, not only for the observation piece to line up when we'll actually do the clinical observation, but also how to schedule that debrief feedback time in a timely way, but that makes sense for whatever clinical service they're on. You know, the clinical service that you do an observation in, maybe in 2 weeks they're off doing something else. So trying to arrange all the meetings can be challenging. Another challenge that was brought up is occasionally defensiveness or resistance from residents about the feedback. You can see here the person highlighted that we have skills around difficult conversations, but that still can be a challenge to have some of those. I'll show you in the next slide, however, that the vast majority of residents do experience this as positive and helpful. Next slide, please. So after the sort of coaching process, after the observation, the written report, and the debrief, our administrative assistant sends out an anonymous optional survey to residents asking for their feedback. So we asked 2 questions. The first one here is simply rating the degree of helpfulness of the communication coaching. And so from those, we've been formally surveying for feedback in this way since 2018. You can see the vast majority of people rate this as either helpful or very helpful. If you go to the next slide. So we also include an open text piece of the survey where we ask residents to put in any additional comments they have about their experience of the coaching program. So I'm going to walk through a couple of quotes here. As you can see, the comments refer to the helpfulness of being able to learn things about one's practice that we aren't always aware. We also often get feedback about the unobtrusiveness of coaching. Residents are understandably, or any of us, understandably anxious about being observed, and can often worry or say that they worried initially or were skeptical that the process would disrupt their workflow. Often they say that after a few minutes they forget that we're there, which is good. We're really true observers and just a fly on the wall. You can see another quote at the bottom there that reflects how coaches, their appreciation for how the coach was able to understand the context and the culture in providing nuanced and detailed feedback. This longer quote in the middle references the residents' appreciation for the data-driven evidence behind many of the recommendations. So with these reports, we often also provide articles or resources to support our suggestions. This person also referenced that the written feedback was a useful resource. So these reports are individualized and detailed and lengthy, but can be used as a resource for reference later on. And then this last quote here speaks to the value of our feedback having exact quotes of what the residents said in response to things patients say, which helps with the specificity and individualization of the feedback. Next slide, please. So to sort of wrap up and end our presentation today, I want to read this quote from Dr. Gawande, who's written about many things, but one of the things he's written about is the value of coaching in healthcare settings. So he writes that elite performers, researchers say, must engage in deliberate practice, sustained mindful efforts to develop the full range of abilities that success requires. You have to work at what you're not good at. In theory, people can do this themselves, but most people do not know where to start or how to proceed. Expertise, as the formula goes, requires going from unconscious incompetence to conscious incompetence to conscious competence and finally to unconscious competence. So this highlighted and underlined part here emphasizes this stages of learning and this developmental approach that we take as communication coaches. So in our work and in our assessment, we aim to really identify where is a learner's skill level in a certain area and help them move along that developmental trajectory. We do this by encouraging small changes at a time, often doing repeated coaching with residents to be able to reinforce strategies and provide ongoing feedback. Next slide, please. And then to finish the quote, he describes the coach as the coach provides the outside eyes and ears and makes you aware of where you're falling short. This is tricky. Human beings resist exposure and critique. Our brains are well defended. So coaches use a variety of approaches, showing what other respected colleagues do, for instance, or reviewing videos of the subject's performance. The most common, however, is just conversation. So related to this self-awareness piece he references, we do see that as a major piece of our work here, improving self-awareness, not only around communication skills, but also how, more broadly, how residents are functioning with patients and team members and how that can be impacted by their own well-being. In fact, the new ACGME milestones released earlier this year, there's now a milestone in the professionalism domain related to self-awareness and help-seeking behavior. So this is certainly something that is being encouraged for residents to be working on and developing skills around. Dr. Gawande here also reflects the challenge sometimes of providing and receiving feedback, which ties to what we discussed previously about skills that our coaches can bring to this work to provide feedback that is helpful and received supportively. So with that, I will stop and thank you all very much, and we'll open it up for some discussion and questions.
Thank you so much to our team of presenters. This is like a really exciting program that, you know, speaking as somebody who's had the experience of being a coach, to see its evolution to this point, including the integration into training and medical education, I think is really pretty amazing. And I'm personally very grateful to the work that this team has done to further evolve and develop it and to expand its reach, frankly. We do have a couple of questions in the Q&A, and depending on time, I might add one of my own. The first one is an expression of gratitude to the team for such great work that can endure throughout the career of all the people involved, both on the coaching end and the coachee end. It's also fantastic how this effort is so comprehensive, kept in context to training life issues, work-life environment issues. It's non-judgmental and collaborative, and also with an array of other wellness-related interventions. This sounds like it came from somebody who's into wellness. I think it's from Dr. Privatera. The question is, do you ever see or hear about alums, people who've experienced coaching, teaching others their newly formed skills? Who'd like to take a crack? Lauren?
I'll start. I can say, having done this in the residency program for quite some time, when I first began in surgery, people were not really certain how this would be helpful to them. And one of the more powerful things that happened for me was going to a surgical conference 2 or 3 years into my position within the department, and an alum approaching me at that and asking if we could have dinner so that he could talk about how to implement something similar to the residency program that he had become a program director of. So I've seen both in a long-term kind of way that people can appreciate the application and the purpose behind it, as well as in a more short-term kind of way when residents say, hey, I've heard about this work that you do because my peer told me not to be terrified or afraid, or whatever descriptive they want to provide.
Thank you.
Yeah, I can comment on this. Just a broader comment, which is in focusing on faculty, the communication coaching program for faculty, I really came to realize how little clinical infrastructure we have for the person of the physician. We have CME about new procedures, new medications, this and that, but really supporting the person, which to me is the most critical part. I don't really think that that's institutionalized in most any medical center. And I think this is a start at that. And I think that's why it's so meaningful to people. It is very individualized. And so I think the alums are less likely to say, you know, you really need to work on X skill. They're more likely to say, you know what, you should really do this, so that faculty or residents will come to us and say, you know, I heard from Dr. So-and-so, this was really valuable. And they sign themselves up.
Mm-hmm.
Also, it's available for faculty for malpractice reduction. So sometimes people do it just because it's on the list of things they can do. But anyway, it is really rewarding. And I think it helps people, both residents and faculty, get back in touch with why they went to medical school in the first place.
I'm really struck as well by some of the feedback I've gotten when I've participated as a coach, where faculty say, I haven't been watched, I haven't been observed doing anything since my intern year. And maybe that was 5 years ago or 25 years ago, but the idea of being observed live relative to bedside and communication skills is both terrifying for some, as the team has described, but then also it allows them to have a feeling of being seen, supported, validated around the strengths, as you all so well articulated, and given some really practical feedback for how to level up, which all of us want to be doing our best. So I appreciate the way that that's delivered.
I just want to underscore that issue that Zipporah brought up about being seen, you know, in a sort of profound and existential way. I do think that's how people experience it, which is kind of amazing since it's a behavioral checklist, but I do think that's true. And on the issue of having been observed, the first person I coached was Ray Mayuski, who at that time was Senior Associate Dean for Clinical Affairs. And after it was over, he said, Susan, nobody's watched me in 40 years.
Mm-hmm.
And, you know, we can all kind of veer off the path in some ways when we don't get any feedback at all.
Yeah, thank you. We have one other question. Well, we have several other questions now. Thank you. The question on the table next is, how is the coach introduced in the sessions to the patients and families, and how have they been received?
I can speak to this. So typically, we're introduced right at the beginning of the visit. This is Dr. So-and-so. She's here observing and joining me today to give me some feedback on patients or my communication with patients. And I would say 99.9% of the time, this is received very well. I can think of one example of a time a patient felt like they didn't want another person in the room, which is totally respected, and then we step out of that visit. Many patients, they often sort of perceive it like, oh, this is good. I'm at a teaching hospital and my doctor's getting some additional feedback. They often joke, you know, okay, he's doing a great job, or give her an A+, which kind of helps alleviate a little bit of the anxiety for the resident. But that's typically how it goes, and it tends to go pretty smoothly.
There have been times where patients have added, oh, this is I love this physician. This is a great, physician. And it's nice for the clinician to hear that validation from their patient. And so it's often not a non-issue.
Mm-hmm.
Yeah, I've had patients say, oh, I can't believe Strong has this program. That is so great.
Mm-hmm.
They really like it. And I think it ups the clinician, if it's a faculty, it ups their HCAP scores, just the fact that we're there. So I think they really like it. Occasionally faculty, I think, can be more nervous about this than residents who are used to being observed. And sometimes they will just say, this is Dr. McDaniel, she's working with me today, which fine, whatever. And then occasionally the patients watching me scribble furiously will say, what are you doing? And then I say it, but it's interesting.
My guess is that at least some of the time, the clinician who's being coached has the latitude to describe what is the role of the coach in the moment. And it sounds like there's a little bit of a range, which is probably useful for the coach to take note of and perhaps to see how it evolves over the course of the coaching session. Another question here, you mentioned that residents through the coaching process are sometimes referred for therapy to help manage stress. Do you feel that the residency training programs help residents fit that into their schedules? And what's been your experience with working with the residencies to help accommodate time and space for that?
I know in my second department, that is a non-issue. But if a resident is needing support in that way, they make time, they carve it into their schedule. They value it that much.
The important point here is that no two residency programs look exactly the same in terms of their time management and structure and rotation. And so in that regard, how it's accommodated probably looks different from one department to the next. But I agree wholeheartedly with Keisha. Anytime that it has come up in the domains that I am in, people are really responsive and want to be supportive. And I think from an educational faculty leadership perspective, they often don't know what the resources are, and so feel really grateful for the fact that the coaching team can help support, build a bridge to those resources.
Mm-hmm.
Also, I think how it's framed, I know in orientation and family medicine, we've long encouraged residents to go get therapy during their 3 years as part of their education. Because it's important to learn how they come across and what that feels like, and to try to normalize the process. It doesn't have to be you come up with some big stressful event. And then having the program accommodate to it. We used to automatically take them out of clinic. I'm not sure that's done anymore, but we definitely will work to make sure the resident can get the help they need.
I'll also mention here that the Collaborative Care Division, EAP and BHP supports have flexible hours, really with the design to be able to meet the scheduling demands of residents and faculty alike. And so I know that that's been a well-used resource, both through the coaching program and through residency programs more broadly, specifically with those service obligations in mind and trying to create open access as best as possible. The next question up is related to perhaps maybe the next iteration of application. Has this program been delivered outside of the physician-patient interaction? And more specifically, what about coaching and communication between faculty and leadership, or between preceptors or supervisors and trainees, with a note that it really could enhance department and leadership culture as well as recruitment and retention? So curious about how else you see this method being useful.
Certainly we, I think, touched on this a bit in the vignette, but there are pieces where we're paying attention to the resident patient and interaction, resident family interaction, but the resident team interaction is something else that we monitor, and depending on what clinical setting we're in. Sometimes the emphasis is more on team communication, presentations on rounds, or how folks are functioning in different settings with peers. So that is a piece that, depending on if there's an identified concern that has to do with less about how the person is with patients and more about how they are with colleagues or others on the team, that is something we will sort of adapt what the coaching looks like to address.
There are several ways where this happens. In addition to what Andrea has described, I can think of multiple scenarios where there are faculty who are aware that we have been present while they're precepting, and who might slyly send an email afterward and say, hey, how did I do? Or I'm trying to work with this resident on X, and can you help me think about how to give my feedback differently because it's not landing or it's not sticking. So there are ways in which we'll touch other team members in the process. The other piece to this is that we think about, as you heard described, some of the other settings where coaching becomes relevant. And so in those spaces, as Andrea has noted, we will see team interactions and do have coding specifically designed around that. And we'll talk about the parallel processes between what makes a good patient-physician interaction as to what makes a good physician team interaction. What's most important relationally, and why does it work? That has resulted in coaching across different faculty meetings, team contexts that are outside of clinical scenarios, research settings with some of our basic science faculty, and other venues too.
Finance meetings, administrative meetings. Communication is communication, so you can code it pretty much anywhere.
I just wanted to add that, people often reach out to us via email. For example, I may have a resident say, I'm working with a medical student. I'm struggling with giving feedback to a medical student. Can you come observe? Can you give me some pointers? So, it's not just encapsulated to the observationals. The session. We do provide, consultation and support via email to physicians and residents and whoever else is interested in improving their communication.
Yeah, I mean, one of the things that I so appreciate about this presentation and the program is that it clearly identifies the skills that comprise good communication, both as a teacher, as a clinician, as a leader, and that several of those core skills are readily observable. There may be other aspects that are role specific or context specific, but there really is a core of those skills, that many of which are on your checklist, that really transfer across settings. And so, getting more and more data about that is quite helpful. It leads me into perhaps the last question.
Can I just say one other thing, Dr. Rosenberg, which is the example that Keisha gave about somebody asking, would you give me some feedback on this? I mean, once that starts happening, then that's data about that culture of feedback has started to take hold, as opposed to being afraid to ask or afraid for somebody to watch you. It's very different once the faculty and residents themselves start requesting it. Then that makes me really happy.
Absolutely. So the last comment and question is, thank you and gratitude for a great presentation. Do you all have plans to conduct a clinical trial to document efficacy and thereby enable dissemination of the program?
I think Kim Van Orden's doing that for us, isn't she?
I don't want to put words in Kim's mouth. I think probably not, but I do appreciate the desire for dissemination and also to be able to evaluate the program in a rigorous way. So perhaps in an upcoming grand rounds, you can share with us your strategies.
It is complicated, as you know. We have published the pilot and we've got a publication about the residency programs and plenty of presentations. Large scale clinical trial is interesting and important and complicated to make sure that it's actually the coaching that's making the difference.
with that particular cliffhanger about evaluation, I will say thank you so much to our team of presenters and to our interpreters, to our tech support, and to all of you for coming, and to wish you a good afternoon. Thank you so much.